This is going to be a presentation on Chapter 5, which is about nutrition support. This is going to include a review of tube feedings or enteral nutrition support and parental nutrition support, which is IV nutrition, that we discussed in the fall semester. But we are going to, in class, go a little bit beyond the foundation that we laid in the fall semester so that you get a more comprehensive understanding of nutrition support moving forward. So here are your learning objectives. We are going to tackle these bullet points during lecture. And then in class, we are going to do more of these application objectives to where you're going to use case studies to calculate parenteral and enteral nutrition prescriptions and walk through how we actually care for a patient when they're on nutrition support. So, the reason that nutrition support is important for you to learn about is because it is so critical in treating patients, particularly those patients with malnutrition. Um, we know from the research that malnutrition or undernutrition is highly prevalent in our hospitalized patients, particularly in our elderly patients in nursing homes. But we understand that whenever patients have poor nutritional status, they're more likely to become full-fledged malnourished. The prevalence of malnutrition is kind of wide. There's kind of a wide range in the research that we have. And part of that is just because of the challenges with conducting such research to determine how many people are malnourished. And another reason is because the criteria for malnutrition or the criteria that's used in different facilities differs a bit. So there's not true standardization among that yet. So that's why we see this wide range. But what you need to know is that malnutrition is pretty prevalent. So the reason malnutrition is such a problem and why we want to identify it is because when our patients are malnourished, they're more likely to be sicker, have less healing, whether it's from surgical wounds or um, ulcers, bed sores, things like that. And all of these things contribute to longer hospital stays, which means that more care has to be provided, more cost has to be accrued to care for these patients. And overall, that reduces patients' quality of life. So we want to identify and treat malnutrition. And while we have specialized oral diets and supplemental foods that we can use, enteral nutrition and parental nutrition or in whole nutrition support is one of our best interventions for malnutrition. So, one of our objectives was for you to describe what are the consequences of malnutrition. So, just think about that for a second and you can pause this. But I'll go ahead and reveal the answer. If you were able to come up with any of these, then you understand the significant consequences of malnutrition. So, we looked at this last semester to see what type of nutrition support is appropriate for a patient. This is the nutrition support decision tree. You should live by this whenever you are a clinical dietitian and working with patients who possibly need nutrition support. So the first question that we are going to ask is our gut functional? Is it compromised or is it totally non-functional? This is the important question to ask first because if our gut is functional, then we can feed the gut. If it works, use the gut. If the gut is non-functional because there is an intestinal obstruction, an ileus, patient has bowel ischemia or intractable vomiting and diarrhea, then we oftentimes will prescribe bowel rest and not feed the gut, and we'll need parental nutrition support. So first question, is the gut functional or non-functional? Our second question is how long is this patient going to need nutrition support? This is important for us to ask because this is going to indicate which access point is appropriate. We have shorter term and longer term access points for both enteral and parental nutrition. So we need to know how long is this patient going to need nutrition support. And then finally, if we did determine that the gut is functional and we utilized enteral nutrition, we need to know like, is the gut fully functional? Is it normal? Is there absolutely nothing wrong with it? Or do we have some compromised function of the gut? Okay, so say we have a patient who didn't quite meet these criteria here, and they can still have enteral feedings, but say perchance they weren't tolerating the enteral feedings very well, we could see that they have this compromised GI function, and then we could specialize the enteral or tube feedings for that patient. So we live and we die by this in nutrition support decision tree, which is why it is hanging out in your binder. So if I were to ask you, what is the difference between enteral and parental nutrition? You can pause it and think about this, and I will go ahead and reveal the answer. If you are able to articulate that one is using the gut or not using the gut, then you have the general idea of what is the difference. Enteral means that we are using the gut. Parenteral means that we are not. Enteral feeding is generally referred to as tube feedings, whereas parenteral nutrition is IV nutrition, totally elemental nutrition. So we'll dive into enteral nutrition support or tube feedings here. This is the delivery of nutrients to the GI tract via a tube, catheter, or a stoma. Stoma just means it's like a surgical opening. We generally refer these as tube feedings, and here you see the indications for enteral nutrition support. So for adults, if we determine that a patient has had inadequate oral intake for 7 to 14 days, they meet the criteria for nutrition support. Or if they are perhaps like going to start radiation therapy to the head and neck, or they're going to have a major surgery, and we anticipate that they're going to have poor nutritional intake for 7 to 14 days, then they also meet the criteria for nutrition support. For pediatric patients, this is a little bit the criteria is a little bit lower for nutrition support because of the importance of nutrition for growth and development during our pediatric years. So if a patient is unable to obtain more than 80% of calorie needs by mouth, if they require 4 or more hours to eat per day, or if they are diagnosed with malnutrition or poor growth, then those that pediatric patient meets criteria for enteral nutrition support. So there are some advantages and disadvantages to tube feedings. Compared to parenteral nutrition or IV nutrition, enteral nutrition support is much more cost effective. In general, parenteral nutrition is very expensive. There's a lot more that goes into creating or compounding the parenteral nutrition solutions, whereas enteral nutrition is a lot easier to come by and cheaper to manufacture, essentially. But in general, with tube feedings, we see reduced length of hospital stays, less need for surgical interventions, less infection, improved wound healing, and we can also maintain GI function by feeding the gut. So there are several advantages to tube feedings. Our disadvantages include some potential difficulty for administering. Sometimes patients don't tolerate them well. And if patients have very high or very particular nutrient needs, sometimes it can be difficult finding an appropriate formula. We don't have as much, I guess, individualization for enteral formulas as we do for parenteral nutrition because parenteral nutrition solutions are compounded like based on a specific patient's needs, which makes it cost more. So, this is what a tube feeding actually looks like. I mentioned a stoma earlier or a surgical opening. So, this is an example of a PEG tube feeding that has been surgically placed. And we have watched a video in class on this, but we will watch this again. So I mentioned determining how long a patient needs a tube feeding previously, and the reason we mentioned that is because the time span that they'll need nutrition support is going to indicate what type of access we should get. So if we have short-term needs for tube feedings, typically we'll use the nose as a route or the mouth as a route to the stomach. So this could look like a nasogastric orogastric or nasointestinal. Most of the time, in a patient who is aware and conscious, they're going to use a naso tube feeding. Um, an example of a patient who would be on an orogastric tube feeding is one that might be ventilated in the critical care unit or ICU, just because it's not very comfortable. I mean, we wouldn't be able to like function if we had a tube going through our mouth, down our esophagus, and into our stomach. So our longer term enteral access points are going to be these ostomies or stomas. So a gastrostomy is a direct feeding to the stomach. Our jejunostomy is the direct feeding through the jejunum. But most likely for our patients with long-term nutrition support needs, they're going to have a PEG placed. A PEG stands for percutaneous endoscopic gastrostomy, which is what I showed you in the picture on the previous slide. But this is also typically how a PEG is placed. Oftentimes, they'll put a line with a light down the esophagus and into the stomach, and that light shines through the skin. And then this can be done at bedside. They'll basically poke where the light is shining through, and that inserts the gastrostomy tube, which will remain in the patient. And that is how the patient is going to be fed through the stomach. So I will have you do this in class, but you can look at this for a good understanding of all of the enteral access points, why we would use those, and what are the advantages and disadvantages of those. These are the typical equipment that you're going to see for tube-fed patients. I just showed you a PEG tube. So there's actually a couple of different types of PEGs. The first one that I showed you was a button gastrostomy, which I'll come back here. See how there's only one opening? Okay. That is a button gastrostomy. So if a patient needs to be fed, we'll just open this clamp here, and the feedings can be administered through there. A PEG J tube is a tube that is inserted into the stomach, but it also passes all the way down into the intestines. So there's a gastric opening and a jejunal opening. So what we can do is we can either feed the patient through the gastric opening and it'll end up here, be fed through this part of the tube, or they can be fed through the jejunal opening, which will distribute the feeding further along this tube. Okay. The other parts of these is that the third piece can be used for flushing or giving other medications. But generally, these are the types that you're going to see. Um, this right here is a pump that is used for continuous tube feedings. So whenever you go to check on a patient in the hospital and they're on a tube feeding, you'll come and look at this pump to see what rate the tube feeding is running at. And you can use that to determine how many calories, protein they're getting from their current tube feeding prescription. But you can also say, okay, is this patient getting what I told them that they need to get? Is the correct tube feeding hanging by the pump? Is the pump at the correct rate? And in class, we will talk about how to assess these things. So a little bit more on the actual tubes. This is what the internal piece of the tube feeding looks like. So this is a little bulb that sort of blows up. It's filled with saline. And this right here is a blocker. So this piece and beyond is what is inside the patient in the stomach. And this prevents this block, and then this bulb prevents the tube from being dislodged. But unfortunately, still happens. Patients will either accidentally or intentionally pull out their tube, and it does have to be replaced. Okay, and then a tube feeding can be hung in a few different ways. There is the ready to hang bags. So you can see this is a Fiber Source HN. That is a type of tube feeding. Or what we're seeing now more often is these cartons. These go upside down. So the osmolite would be upside down, and it hangs just like these tube feedings, except this is a hard plastic, so it's basically less likely to get punctured and be ruined. We also have clear bags that don't have anything in them that we can use canned formula to fill, and I will show you an example of that in class. So, when we determine that a patient has a functional gut and we want to feed them through enteral nutrition, we have to determine, okay, well, what is the type of formula that is best for this patient? So last semester, we talked a lot about what the different types of formulas are, and we talked a lot about nutrient density and osmolality and viscosity. So what you need to remember is that most of the facilities that you work at, or every facility that you're going to work at, is going to have a contract with a particular company that provides tube feeding formulas. And as a dietitian at those hospitals or facilities, you're going to get really comfortable with the tube feedings that are provided. So you'll have a formulary book like what we use digitally in class, and you're going to get really familiar with the formulas that are available. But as for now, whenever we are just hypothetically speaking about patients and tube feeding formulas, we can use this decision tree to determine which type of tube feeding formula is appropriate. The first thing that we want to know is, again, is our gut like fully functional? Is it perfect, pristine, proper? Or do we have some type of impaired digestion or absorption? If we have a good functional gut, we can determine, does this patient need a fiber modification? If so, they're usually pretty good with the standard formula. If they need a low residue, low fiber formula, we have formulas such as that. Then we'll look like, okay, does this patient need a really high calorie or a high protein, or a formula that has specific fish oils or wound healing elements? Then we might need a more specific or specialized formula. If they are a patient that has renal disease or congestive heart failure and fluid restriction is really important, then we would need a higher calorie formula that is more nutrient dense, that has less fluid to help with the fluid restriction that that patient needs. So we will work through this some more, but y'all got some practice with this last semester. Now, whenever we look at the general composition of tube feedings, we are looking at the protein, carbohydrate, fat, and micronutrient components. What you need to know about protein is that it's typically in soy or casein forms and usually is providing 10 to 15% of the calories in a standard formula, but up to 25% for our specialized formulas that need really like high protein. Um, for our patients who do have like some compromised digestive function, but their gut's still functional, we can offer protein that is a little bit more chemically broken down, you could say, and in the form of peptides instead of really large proteins that are whole and intact. And this can help with our patients who have malabsorption or maldigestion. We can also offer tube feeding formulas that have specific amino acids that are known to support a specific disease state or support wound healing or something. So that's kind of the variability that we see in protein in our tube feedings. For carbohydrates, all of our tube feeding formulas generally are going to be lactose free, and that is to help with tolerance of tube feeding formulas. Many of the tube feeding formulas are going to include fructooligosaccharides. And if you remember, these are the types of carbohydrates that ferment in the colon and produce short chain fatty acids. They provide fuel to the cells that line the gut. They help to support a good, healthy gut microbiome and help to maintain GI integrity. However, we can provide formulas that are considered low fiber or low residue. So they can have less fiber or they can be fiber containing. And whenever you look at the formulary, you can identify those. Sometimes we can prescribe formulas that contain soluble fiber. we want to just be careful with that because we don't want to basically stop up the patients too much because it does increase fluid needs because soluble fiber is so hydrophilic. Fat in a tube feeding is generally in the form of corn, soy, safflower, or canola oils. And this is where some of the discourse comes up about tube feeding formulas and the quality of the nutrients that are in them. So there are some newer types of tube feeding formulas that are called whole food formulas or blenderized tube feeding formulas, which we can talk about in class. But to have a more, let's say, anti-inflammatory or immune supporting tube feeding formula, we might see some that contain higher amounts of omega-3 fatty acids or have fish oils added to them to make them a little bit more supportive for patients who need that. For our tube feeding formulas, all of them are designed to meet the DRIs for vitamins and minerals, specific to if it's an adult patient or a pediatric patient. And then our specialized formulas can also have additional micronutrients to help with wound healing or metabolic stress or whatever, depending on that patient's needs. So, whenever we're talking about calorie density, we're usually looking at 1 to 2 calories per milliliter in a tube feeding formula. And this is where we get like the isosource or isosource 1.5 or 2 cal HN. Those numbers are indicative of the calories per milliliter or the nutrient density of that formula. We need to know the nutrient density of the formula because that helps us to determine which formula is best for the patient. So over time, you're gonna see like, oh, I just did a nutrition assessment on this patient. They have very high protein needs, and a standard formula just isn't gonna cut it for them. So I'm gonna use a higher density formula to help meet their calorie and their protein needs. However, it is important for us to understand the osmolality of these formulas because the higher we get in the nutrient density, the higher the osmolality it's going to be, which means that more water is going to be pulled towards the gut, which can lead to dumping syndrome. So this is one of the complications of tube feedings. And if we're not paying attention to the osmolality and we have a patient who's at risk for dumping syndrome, we could cause some harm there. So whenever we decide a patient needs enteral nutrition, when we start it is going to be based on our own clinical judgment as a dietitian, what our facility says should be done, and then also we're going to consider evidence-based guidelines. So in general, for hospitalized patients, Aspen says that we should meet 25 to 50% of a patient's needs on the day that the tube feeding is started. For our critically ill patients, it's important that we initiate tube feedings within 24 to 48 hours of admission. So, say we have a critically ill patient who is at risk for malnutrition, we want them to start tube feedings as soon as possible because we understand that if they're undernourished, they're going to have poor outcomes. As far as advancement goes, we are going to basically look at how the patient is tolerating the current tube feeding regimen. For our non-critical patients, a good goal is to reach the 100% of the goal rate within 48 hours. And for our critically ill patients, we want to get up to 80% of the goal rate within 72 hours. Now, with our critically ill patients, it can just be a little bit more challenging to meet the goal rate because perhaps they're not tolerating the tube feeding or their whole clinical and medical picture is just really complex. And maybe there's reasons that the tube feeding has needed to be started, stopped, and interrupted. Our tube feeding prescriptions can be for bolus feedings, intermittent feedings, or continuous feedings. What I showed you earlier with the tube feeding pump, that is a continuous feeding device. So continuous feedings are given all throughout the day. I'm going to fix this. All throughout the day. And this is wrong. It does not give patients freedom. So if they're on a continuous feeding, they're essentially hooked up to that pump all the time. A continuous feeding regimen might look like isosource 1.5 at 50 milliliters per hour times 24 hours. A lot of times a patient will be started on a continuous feeding, and as they tolerate that, they might be switched to a bolus feeding regimen. So a bolus feeding regimen is meant to mirror more like meal times, and to give patients a bit more freedom for them not to have to be hooked up to something all day. So a bolus just means that they're going to get a bulk of tube feeding formula at a time. So an example of that might be 250 milliliters of isosource 1.5 3 times per day. Intermittent feedings are a style of continuous feedings, but only given at certain times of the day. For example, it might be at nighttime, called nocturnal feedings. And this can just be to ensure tolerance, but also give the patient a substantial amount of calories and protein during the night in a way that we can still encourage them to consume foods and nutrients through an oral diet during the day. So, whenever we are determining a person's nutrition prescription for tube feedings, we have to start with their dosing weight or their dry weight, their the formula that's best for them, their energy needs, their protein needs, getting the goal rate, and then making recommendations for advancement. So in class, we're going to talk about how to approach tube feeding prescriptions. When we write a tube feeding prescription, it's oftentimes going to look a little bit something like this, but we're going to get some practice with this. So, say we have a patient who has started nutrition support. These are the things that we want to take a look at. And you'll notice that these are divided by patients who are unstable or critically ill versus stable. So, think like ICU, CCU, or on a normal floor. So, we want to look at the nutrient intake and output, the electrolytes, blood, urea, nitrogen, and creatinine. This is like fluid electrolyte, renal labs, um, magnesium, phosphorus, and calcium, liver function test, triglycerides, weight, their hydration status, vital signs, bowel function, their blood sugar control, and their nitrogen balance. Some complications that can be seen with tube feedings include GI complications, possibly diarrhea, constipation. Diarrhea is going to be more common. Aspiration is one. We can have aspiration of the gastric contents. It can go up through the esophagus and be aspirated into the lungs, which can cause problems. So placement of the tube feeding is really important. Dehydration and electrolyte imbalances are common if we're not providing the patient with sufficient fluid. Overfeeding or underfeeding can occur. Hyperglycemia can happen if a patient is in this like hypermetabolic state and their blood sugars are just out of control. But refeeding syndrome is another common complication. So, refeeding syndrome is a condition that we want to really pay attention to with patients who have malnutrition or are at risk of malnutrition. And all of this goes back to metabolism, what's happening. So, if we have a patient who has been quote unquote in a starvation metabolic state, what we see is gluconeogenesis slows down. We start to use free fatty acids to create ketones to fuel the body, and overall metabolic rate declines. So, the issue is that whenever we are malnourished and this metabolic shift occurs, we start to see lower levels of electrolytes, potassium, magnesium, chloride, phosphorus. All of those are really critical, and thiamine. All of those are really critical to carbohydrate metabolism, and normal fluid and electrolyte balance inside the cells and outside the cells. So the issue is that whenever we reintroduce carbohydrates for a person who has shifted metabolism to this like ketogenesis situation, um, they start to require a lot more phosphorus to lock glucose into the cell. So if we are depleted of phosphorus because we have been starved, okay, we don't have enough phosphorus in the diet, phosphorus levels get really low in the cell, and then all of a sudden we introduce glucose and there's a high demand for phosphorus to lock glucose into the cell, we can develop severe hypophosphatemia. And in addition to that, whenever we introduce carbohydrates, whenever we've been in the starved state, we see hypomagnesemia, hypokalemia, hyponatremia, and thiamine deficiency because all of these are involved in glucose metabolism. Here is a picture that kind of explains this, and we'll look more at this in class. But basically, when we're in this starvation mode, our metabolic rate decreases. These electrolytes, potassium, magnesium, phosphorus, they leave the cell to help normalize blood levels of these. And we start to produce less energy, right? But whenever we introduce carbohydrates again, the potassium, magnesium, and phosphorus that was hanging out in the blood rapidly moves back into the cell to help create ATP. And that drastically decreases the blood availability of those electrolytes. Um, the reason that that is problematic is because whenever we deplete the blood of those electrolytes, we start to see some really significant physical symptoms, and that is what refeeding syndrome is. So with hypophosphatemia, we can see cardiac arrhythmias, impaired respiratory function. With low magnesium, we can see tremors, muscle twitching, again, cardiac arrhythmias. Hypokalemia, we can see cardiac arrhythmias. And then thiamine deficiency, we can see a form of encephalopathy. So refeeding syndrome is very, very serious. If we have a patient who is malnourished and needs nutrition support, we really, really need to determine if this patient is at risk for refeeding syndrome. The way we would do that is we would check this person's electrolytes. And if we determine they were at risk, in addition to our tube feeding prescription, we would recommend supplementation of these micronutrients as well as a slow introduction of the tube feeding of the carbohydrate to reduce the effect of refeeding syndrome in that patient. So here's a question. Which patient is at greatest risk of refeeding syndrome? Is it the 42-year-old male with 20% weight loss in 1 month due to significant dysphagia from head and neck radiation? Or is it the 65-year-old female with osteoporosis and uncontrolled hyperglycemia who has dysphagia after a stroke? I'll let you think about that. You can pause it, but I will go ahead and reveal the answer. The greatest risk of refeeding syndrome is for our patient who has malnutrition. So we've seen this significant weight loss. They have head and neck cancer that they're getting radiation therapy for. So we definitely want to do a very particular initiation and advancement of that patient's tube feeding to reduce the likelihood of refeeding syndrome for that patient.